So friends, good morning, and I'm sure people are very eagerly awaiting for some new procedures into the armamentarium of ophthalmologists. Can we know how many of us are presbyopic and wants to undergo surgery? They can raise their hands. So,
I like my glasses though.
correct. In spite, the presbyopia is a new armamentarium, and probably a lot of work is going through internationally to complete the correction of refractive errors. So friend, as Dr. V.K. Raju has given almost the overview of presbyopia, and it is not a disease what accordingly every one of us, but it decrease of near vision due to gradual loss of the accommodation mechanism. It is caused by lens elasticity and which is independent of the refractive error. In accommodative function, accommodation refers to an lenticular based change in overall refractive power, the eye to obtain and maintain the retinal image of a near object. It is in focus. Defocus bar is considered to be the primary stimulus that controls the accommodative response of an individual. When fixating near the objects, near triad, and changes in the accommodation, increase in the lens power, changes in the versions as convergence and pupil constriction, accommodative miosis or near miosis has to be properly handled. The presbyopia correction is now increasing in demand because the tendency of societies in products and interventions which improve appearance psychologically, every day of life, and overall the quality of life, such as Botox injections, plastic surgeries, hair loss treatments, and surgical treatment for presbyopia. So, as you know, after cataract surgery, the most planned ophthalmic surgery is now refractive surgery. And amongst that now, because of the opening of new domain of presbyopia, people are very much interested to have this more correction and more techniques into this. Non-surgical presbyopia is reading glasses, contact lenses, and contact lenses which can have monovision as well as the multifocal and bifocal designs. So an overview how we can correct the presbyopic refractive errors. There are monovision concepts where it has been done on the corneal approach and to lenticular approach by laser and inlays which do a flexi-view, Vicro lens and acufocus. So the inlays I have been, they had come in between before 10 years, again they were out of practice. So again in last 3-4 years, it is attracting so many new concepts in presbyopic correction. The multifocal approach is whether you operate lens or you perform corneal procedure. The peripheral presby-LASIK in cornea was very much awaited and ignited. Central presbyopic LASIK and femtosecond laser, which is a recent addition into that. In lens, it is the Restore, the Rezoom, the Technis, and others. They have now prime location into the multifocal pattern of this correction. And in accommodative, which is recently quite interesting to have accommodative response, they perform scleral surgery and lens surgery. Scleral surgery, in spite, was with implants and incisions, but it could not it could not progress to the satisfaction. In lens, the Crystal lens and others, they have given excellent results for accommodative IR. In sclera, the scleral implants, the PMMA, 4 implants are done situated near the limbus, weakening of the, altering the sclera over the ciliary body. And in other approach, you take scleral incisions, weakening or altering the sclera over the ciliary body again, and ACE laser more recently. The corneal approach of monovision approach is multifocal prismatic corneal lenses or inlays. In monovision, usually dominant eye is the distant correction and non-dominant eye is for near correction. That means the myopic undercorrection, hyperopic overcorrection, induce myopia, and it is achieved by LASIK, TRK, conductive keratoplasty, and cataract surgery. In monovision, it's very important to good patient selection and patient information and good counseling. The trial lens, better with contact lenses, age above 40 years. Happy patients are those subjects with low hyperopia and not used for wearing glasses. The correction is no more of 1 diopter to 1.25 diopter. The effective in vision quality decreases stereoscopic vision, decrease in perception of the depth of the focus. In conductive keratoplasty, the radio frequency energy and mark around the central cornea, this one like corneal collagens, they start shrinking, cornea is flattening in the area and steepening in the hyperopia. The multifocal ablations done by excimer laser, corneal lenses and inlays, the easy to remove of the implant if required without loss of tissue. It is stable centration of the lens over time, and there is no flap and better stability in acufocus and reversibility in conductive keratoplasty. Less invasive techniques like clear lens cataract excision or clear lens extraction would be lens-based surgeries. The monovision, again in lens, multifocal IR, accommodative IR, and femtosecond laser ablations. The silicone IRs with photosensitive molecules, they are quite in good development and stages. Post-surgical refractive manipulation, it is usually for monovision. The multifocal IRs, they usually, the results depend on the lens optical characteristics, pupillary diameter, and corneal astigmatism. Precise surgical maneuvers of lens placement often cause decrease in the quality of vision, and techniques multifocal, restore, and Zeiss trifocal are more popular. In accommodative lenses, the various lenses are recently come up, and the mechanism is by ciliary body muscle contraction, forward displacement of lens approximately 1 diopter. It is FDA approved. Accommodation IOs, the future, the smart lens accommodating IOL, the real accommodating lens, thermosensitive acrylic gel within the lens capsule, receives capsule and shape of the moves along with it. Accommodative IOs is probably the future. The nucleus accommodating IOL, real accommodative lens, they are on the verge of attracting the ophthalmologist around. Femtosecond prismatic laser possible applications are the progressive sclerosis of the crystalline lens, presbyopic effect according to Hulmer's theory, and possible relaxation of the lens through new microincisions and lensectomy. So what is important is selection of the patients and perfect counseling. Age and pre-existing refractive status, say between 40 to 45 years, the corneal approach is better. The monovision or multifocal laser can be tried, and conductive keratoplasty for corneal approach. If people are between 45 to 60, the majority they want e-metropes, and they are happy with corneal injuries. And people who are more than 60, they have clear lens extraction. So patient selection criteria is always has to be done carefully again for professionals and hobbies. The professional near vision surgeons of other microscope users accounts, architectures, etc., and specific hobbies like hunting, shooting, exclude monovision approaches. Then professional far vision for drivers or specific night jobs, then you can excuse in night guard, etc. Exclude multifocal approaches. Explain the realistic objectives and possible complications for limitations. Exclude very high expectation of the patients. Perform accurate monovision and multifocal trials preoperative, and carefully select the procedure. The 53-year-old woman lower than minus 0.75 diopter and 520 micron corneal thickness, the monovision laser, if good monovision is tolerated or tolerability. The 52-year-old employee, he may be treated with corneal injury. 49 years of old hyperopes, the taxi driver, the hyperopic laser with sight monovision or CK. So 45 years of old engineering, hemetropic. 63-year-old rheumatologist, the clear lens extraction. 50 years of old secretary with +2 CLE. So the presbyopia surgeons, it is principle, the 5th century of PC, Hippocrates. And in 2015, presbyopia surgeon must have access to monovision. And after all, we have got excellent speakers, those who would be enlightening us on different aspects of presbyopic surgery. Thank you very much.